So we are actually getting a great spread across all of these. We just had the poster session, and it's been nice to see a lot of different areas of interest highlighted to the clinician. There is data in the frontline space. We have updated data that will be presented at the oral session to look at long-term outcomes with standards that we already have in practice. There'll be the 5-year update on the data for the Keynote 426 study, axitinib pembrolizumab. There'll be the 4-year follow-up for CLEAR, which is the lenvatinib pembrolizumab registration trial. And I think these long-term outcomes have been long awaited to do a comparison between what we see for IO-TKI combinations like those two versus ipilimumab, nivolumab, which has been around much longer with longer follow-up up until here. So that data is to be presented and very exciting. At the poster session, there's data also in the pre-treated space. The biggest presentation arguably at this meeting for kidney will be the CONTACT-03 study, which is a randomized trial that compared an immunotherapy pre-treated patient, the strategy of single-agent TKI, so cabozantinib monotherapy versus the combination of TKI-IO, carrying on combination after mostly prior combinations with atezolizumab, cabozantinib. We haven't seen the data yet. That'll be at the oral session, but we know already from the press release that that was a negative study for PFS and OS. So I think it's very instructive because in real-world practice, there's a lot of off-label use of combinations in pre-treated patients, and this data now, would be more of a cautionary tale and would, I think, tell treating physicians to be more cautious about using combination after combination. There are other studies coming that won't be presented here that will look more into other combination strategies, but for the time being, we have nothing to support such a strategy. I like that there's a lot of non-clear cell kidney cancer data presented at this meeting. There's a number of smaller trials. There's a lot of retrospective data. At the poster session now, we saw some data from the IMDC looking at rare variants retrospectively. We saw data from a number of smaller relevant phase 2 studies looking at combinations in the front line. There's the long-awaited lenvatinib pembrolizumab phase 2 data in that space, which is decent size and looks at different non-clear cell variant with a very good efficacy signal throughout. Relevantly, not only papillary patients, but also chromophobe kidney cancer patients seem to benefit from that combination based on this phase 2 data, lenvatinib pembrolizumab. There's updates to the cabozantinib nivolumab combination, which was sort of the lay of the land in the first line in the last 2 to 3 years, and that continues to look good in terms of many of these responses being durable and a good PFS signal in that space. There's a triplet trial that is being presented, which combines cabozantinib, nivolumab, and ipilimumab in untreated non-clear cell variants, and provides a similar signal to the Cosmic 313 study where this concept was tested in a randomized fashion in clear cell. So on this small non-clear cell trial, again, the combination of 3, cabozantinib, ipilimumab, nivolumab, seemed to have been a difficult regimen to give with a high toxicity rate, a high requirement for systemic corticosteroids to manage side effects, and a notable discontinuation rate. There's efforts ongoing by the investigators now to adjust that regimen and make it more tolerable. So that study is still ongoing and now looking at a lower TKI dose at start. And hopefully that'll do the trick. But the efficacy signal seen with this 3-drug combination, at first glance certainly wasn't impressively different from the duals that we mentioned before, lenvatinib pembrolizumab or cabozantinib nivolumab. So I think that's very helpful in our efforts to work towards dedicated strategies for non-clear cell patients. On the biomarker end, the non-clear cell space also had posters to offer. There's immune characterization of chromophobe kidney cancers that was presented by the Dana-Farber group. we'd seen some of that data before, and they built that out and looked at expression signatures, and it goes to show, which now is well recognized, that the immune biology of that subtype is vastly different and certainly much less characterized by sort of a dormant, exhausted, adaptive immune cells that can be reinvigorated with the strategies that we typically use successfully in clear cell kidney cancer. So it's very obvious that we need a different approach in that space. And then there's biomarker data from a number of trials that have previously been reported. The HCRN study of nivolumab in the Frontline had two posters, where investigators looked at immunofluorescence scores and also transcriptomic data, trying to decipher which patients might benefit more from therapy. And I think more relevantly than making those points, those efforts show that there's a real effort and a real potential in conducting these studies with a dedicated and detailed biomarker piece, peripheral blood assessment and tumor tissue. Along the same lines, there are cooperative group investigators that are showing data from the PROSPER trial. Naomi Haas was the poster presenter for that, looking at the feasibility of getting tumor biopsies at the entry into a large-scale clinical trial. And there's a vast majority of patients that went on the treatment arm on that study, which was pre- and post-operative immunotherapy, had a dedicated tumor biopsy done. It was shown that was safe, that there was good fidelity when you compared the findings from that needle biopsy with the nephrectomy specimens that patients ultimately had, and there were no delays in getting patients on study, started on treatment, and so forth. So I think those efforts are to be commended, and I think show that there is not only the opportunity, but there's feasibility in getting these biomarker studies done as we enroll patients on our trials.